I think when we hear models, the first thing that I see therapists thinking is, what is going to be the 1 + 1 is 2, right? X + Y is Z. How am I getting paid? Where I really encourage therapists when they look at these models coming out, even if it does not look like this is something that's going to be immediately beneficial, like in your pocket right away, you have to look at the way it improves the perception of therapy.
Kick it.
Welcome back to Strata Stories. Today, you will hear from Dana Strauss, a PT and policy health expert. In this two-part series, Dana's State of the State breaks down the most important federal programs, models, and policy shifts affecting rehab therapy today, where new reimbursement and revenue opportunities may be emerging, how therapy can better provide its value to CMS and shape future payment models, and what this means for clinicians' purpose, practice sustainability, and long-term profitability. Let's get started. All right, Dana, welcome back to Strata, and thanks for giving up some of your time. There's a lot of confusion and just general murkiness, I would say, in the PT/OT sphere with what's going on with this administration. And I would love to hear, what are some new things you're hearing around Washington and legislation, and let's start from there.
Sure. Well, thanks for having me back. This is a fun podcast to be on, and I love this new format. And I would love to tell you a little bit about the state of the state. It is an interesting time to be in health policy. And, you've probably heard me say before, I think it's really important that therapists have to have your finger on the pulse, but like a palm on the body of what's happening in DC is not a bad thing. So, like big themes, everyone's heard of this Make America Healthy Again, right? This is a term that was coined by RFK, and it really stuck. And the MAHA movement, or the MAHA essence, actually was impactful in getting the president elected. So there's folks that, right, they voted for President Trump because they aligned with the messaging around MAHA. And there's so many different ways you could kind of think about MAHA, but the way that the Center for Medicare and Medicaid Services is sort of framing it as, we're going to address chronic disease at the root cause. We're going to try to enable beneficiaries to take care of their own health. We're going to elevate digital health and find new ways to pay for digital health applications. We're going to look to provide greater access to care in different ways, a lot of flexibility, kind of letting the market forces do their thing. And then most recently, we'll talk about a model that was just announced very recently, the MAHA Elevate model, which we'll get into. And that's a model around paying for lifestyle and functional medicine. So again, MAHA is important to this administration. And so what happens is that when the president just puts out their platform and puts out their executive orders, then it's the job of the agencies like Center for Medicare and Medicaid Services to implement those through regulation. So, right, the law is passed by Congress, and then based on the law, there are updates made to that, how those laws are implemented on a regular basis. Some things are put out new, and some are just updates to policy.
Tell me about what's the MAHA Elevate model. What does that look like for your average, rehab therapy provider?
Sure. So the Elevate model, I'm going to actually look at my note here because it's so new. I haven't read the entire thing yet. So MAHA Elevate means brings lifestyle medicine to original Medicare, and it is called the Enhancing Lifestyle and Evaluating Value-Based Approaches Through Evidence. That's Elevate. So it's almost like we've got a lot of acronyms. It feels like they're making an acronym and then they're figuring out what words fit the acronym that fit the model. We'll talk about the access model after that. So the Elevate model, from what I'm reading in the press releases, there's a lot more information to come out, including the notice of funding opportunity. So this is going to be like a grant program. So there'll be $100 million available, and up to 30 grants will be given. and it'll be for novel approaches to addressing chronic disease using concepts around lifestyle medicine and functional medicine. So there are certain schools of thought around different ways to approach health, and they're not reimbursed in Medicare or through most commercial plans right now. So it could be things that are exercise based. It could, which is to me, this could be, and again, a lot of reading to do on it still, but it's pretty open ended. This could be a really good opportunity for therapy, truly. It could be things like acupuncture. It could be nutrition, supplements, dietitian work. So, right, ways they're going to look at whether or not when they give these grants to organizations that apply, and they're going to select up to 30, whether or not based on what they implement, are these alternative approaches going to yield better outcomes at a lower cost over time. So pretty open-ended. It doesn't look like it has like a downside risk to it. Although again, I haven't read it in a lot of detail, but if for anybody listening, if you look it up and by the time this comes out, I'm sure there'll be more on it. I think it's a really good potential opportunity for all of the therapy practice types.
So if there's 30 grants, and if you're a small practice owner, would you probably think I'm too small to provide enough data and care to get this? Is this more of like a larger entity availability that we're talking about? Like maybe 100, 200 practices, should they be applying for this?
I mean,
Or could
I would
smaller
certainly
owners
partner. Yeah, because they're going to be looking to divide up this money. 30 is not a large amount, but it's also, we're not talking about billions. It's $100 million is a nice chunk of money. But to divide that up, right, it's a couple $1,000,000 per grant, but it's allowing reimbursement for things that are not covered right now through billing codes in Medicare. So, just off the top of your head, you could get together even a couple of, small practice chains could come up with a novel idea. So you could also combine with other disciplines like therapists work with let's say a nutrition or dietitian group and come up with a program that they can provide to beneficiaries that is reimbursable through this grant money. And then those patients may also be getting traditional therapy. I think when we hear, you hear models, the first thing that I see therapists thinking is, what is going to be the 1 + 1 is 2, right? X + Y is Z. How am I getting paid? Where I really encourage therapists when they look at these models coming out, even if it does not look like this is something that's going to be immediately beneficial, like in your pocket right away, you have to look at the way it improves the perception of therapy by the public, right? So a place to elevate the possibilities of the therapy world and also developing partnerships with traditional medical care where this is an opportunity to show what you're capable of and how you can deliver results for patients. So, who do you get to meet because of this? Who are you offering? What practices, let's say you develop and elevate, you develop a novel product to provide to patients. Sometimes patients are not well served by traditional medicine. No shocker, right? There's not a good medication for it. There's not a good injection for it. Well, there's chronic disease management, but other than that, that's what primary medical care does, right? They don't have some magic wand to address chronic disease burden or chronic pain. But if we can create a program, for example, in this new model, and then we can approach practices, everyone deals with the complexities of managing patients that are difficult to treat, that they often will farm off to specialist medicine, and that's very costly. If that practice that you're, in your community is part of an accountable care organization, they don't want to default right to a specialist because it's very costly. So if they can send a patient instead to a program that you developed where you have this grant money through Medicare, well, that's a much better potential option. It's another tool in their toolbox. We have to be kind of throwing ourselves and our skill sets at traditional medical care and saying, like, we're a tool. Here's an example of what we can do. Oh, and by the way, now that we've shown you that, let's show you how we can partner. So when your patient comes in with, knee osteoarthritis or shoulder pain or back pain or gait abnormality, we can see them right away, whether it's for this, new program, or we're going to give them traditional therapy, or both. Right. So I like that. I like that message to keep coming across to therapists.
I was, as someone who constantly analyzes the industry, I will say that I would think, especially the younger therapists, do see physical therapy as more of a functional type medicine to help chronic disease, especially exercise. And that's why I think there's a big boom in cash-based services in the wellness field. Even new physical therapy, they'll be, hey, I'm active impact physical therapy and wellness. And so this is screaming, hey, if you're a large wellness organization, this is the perfect opportunity to expand and get more data so that eventually maybe you could get reimbursed on an insurance level. What do you think about that?
100%. And I would be looking, I didn't even think about that. And that's genius. It's also a great opportunity to put us on the value-based map. Again, like, we've got folks like you described where they're thinking this is a cash-based thing. Well, the whole idea of a innovation center model is to prove something works. And then when they do, then they can put it out into all of Medicare, right? It becomes a reimbursable. That's the whole point of the innovation center. It's research and development. Once it hits a bar where they say, oh, this improved quality or decreased costs or both, then they can scale that. So you can take these services that right now we don't have good billing codes for, we don't have any billing codes for. We can prove that we can move the needle. And there's no one better, that more interested, as long as you point out, you make the link. There's no one more interested in this than a primary care group that's participating in an accountable care organization, especially when they're in downside risk, which is now mandatory, right? Through the latest physician fee schedule, we now have a mandatory progression to risk in the Medicare Shared Savings Program, which is about half of primary care docs are participating in right now, either that or one of the other ACOs. So if you're an ACO, you want to reduce spend that's high cost and is not bringing value and is not helping reduce that high cost spend. And when you can create a program like this, PTs can start thinking about this as, we have a host of services. They're not reimbursed. This is a mechanism to get reimbursement through a grant, show it works, then talk about it, write about it, and share it to those with the incentive to care, like an ACO, like a primary care group taking risk. But that takes a little bit of research. That takes knowing who in your market is participating. How do these programs work? What levers help these providers make money? And then showing you through this new program. And by the way, the incredible skills and high value skills of therapy and what you do for patients, how those lead to success for the ACO. And oh, by the way, for patients and for the therapy group.
Since I've been listening to you for a while and you keep talking about ACOs and PTs becoming more involved in legislation and things like that, have you seen any examples or have you met any new coworkers per se that are almost listening to your advice and PTs coming to a legislative front to do these things?
So if we break down first, what is legislation versus, because policy is kind of the big word, right? Policy means anything, at least on the public policy side, anything that changes the way something is funded or what is allowed to be done, or both. So you create laws, create laws in Congress, you fund budgets through Congress, right? So the physician fee schedule, for example, is funded by Congress. And then CMS has to take that money, that budget, and break it up so that it covers all spending, right? So things happen slowly in Congress, right? You have to have a bill that goes through the Senate and goes through the House, is exactly the same, is reconciled between the House and the Senate after they pass. And then it has another usually larger bill of a compilation of bills that it can sit with to end up as a final bill vote across both the House and the Senate. It has to go through committees on both the House and the Senate side. No bills ever get voted on or discussed unless they have gone to committee. So it means someone has to be willing in the House and the Senate and those committees to care about the bill. So you have to find someone who has a reason to care about that bill because of how it impacts their beneficiaries, for example, like the people in their state. And because they feel like it matches the direction that they're trying to go in their own, political, like their political work. So legislation is hard and it's expensive. If something is going to cost money, good luck, right? You have to find a way to pay for anything that goes through Congress. You can't just, like we say, there's a wonderful bill that's sitting, I don't even know if it's in the House and the Senate, this bill on falls, right? And addressing fall risk. It's still going to be a coster. It costs money to pay the people that are going to implement that program if it's passed. So anything could be a totally awesome program and something worth putting into law and paying for, but it has to then be paid for. And that's like most of the barriers in Congress are because things have to get paid for. Right. So there has to be a give and take. And this is where politics comes in. So there's a lot more politics and a lot more like things to navigate and negotiate when it comes to Congress. Things can take years to finally make it to all the steps between the House and the Senate and having a bill that votes on it and figuring out how to pay for it. It can take years. But once something is in place, Congress has voted for it, it's a law and it's paid for. There's something in a budget that pays for it. Then someone like the Center for Medicare can take that law and those funds, and they actually put all the details around it. They figure out how to allocate the dollars to implement that law. They're think of them like interpreting. They're implementing, but it's hard to say they're not interpreting also. So they're trying to put together a way to make whatever's made law into practice. And so I personally think we should be spending a lot more time as an profession, a group of professions, thinking about the Center for Medicare and Medicaid Services. They already have the money. In the Innovation Center, they have the flexibility, and the money is outside of the physician fee schedule. It's in the CMMI fund, which is funded every 10 years through Congress. It's funded $10 billion every 10 years. They can do a whole lot of flexible things with it. The Center for Medicare through the physician fee schedule can do a lot with that money. And I will segue this because it's a good opportunity into the physician fee schedule. And what I think is worth reiterating to therapists is the physician fee schedule over the past couple of years has created new billing codes for primary care and behavioral health as part of primary care de facto. And they have increased the weighting that primary care codes get. And when you look at, as therapists, when we look at what CMS is doing, and we think about why they're doing it, what goals they're trying to reach, right? That's how I think we should be thinking about how we should approach the Center for Medicare, about what we would want and align that with what's good for them. So if CMS is already, this is now the second administration in a row, different parties. So this is a bipartisan effort. Primary care is well underfunded. Primary care physicians and APPs are underpaid compared to specialists, right? So we have valued specialty care heavily. We've given them a lot heavier weight to their codes and their services. And there's a lot of services in primary care that have no payment mechanism. Coordinating care, coaching and training, and navigating patients, all of those things until recently have had zero billing code. They now have mechanisms through fee for service so that physicians can build out teams that can do things like community health integration and principal illness navigation and patient education and a whole host of things. Behavioral health also has been a benefit of this by new types of providers being brought into Medicare, new billing codes, new integration codes, right? So we know Medicare's doing this for good reason. They want more done in primary care to prevent all the specialty care and all that high cost acute care. So if that's what they want, then what do you think we should be thinking about to propose, because we can do this, we can propose ideas to the Center for Medicare that solve the problems they're trying to solve. What do you think we should be doing with Medicare as an organization, as let's say it's the APTA or any organizing body or any group of therapists? What do you think we should be proposing if this is what they're trying to solve for? I'm going to ask you.
Oh.
Creative. I mean, I don't mean like it's a
So here's
direct answer, but
it just as me thinking about something, especially with primary care,
yeah.
here's a trend. So I do a lot of social media work. I do a lot of industry work. And there's a lot of people that have been alienated by primary care and specialists, right? And they've, been gone through like, oh, I don't know what's wrong. I think it's this. And so, especially if you have a metabolic endocrine disorder. So like, I struggle with PCOS, which is simple, but I've done years of research. And so they'll just keep sending you to specialists and you pay for a lot, nothing ever happens. And so now one thing I've noticed is on Instagram, there are people that are either nutrition specialists, personal trainers and coaches, and they're like, hey, exercise, nutrition, sleep, and stress management are one of the main ways to control this, whatever chronic disease. And so if you actually go on Instagram and you look up like something like PCOS, which is metabolic, but at the end of it, it's very related to exercise. I kid you not, you could find hundreds of coaches that have cash-based programs to manage symptoms, and it's all through lifestyle changes. And I get more information from Instagram coaches than I do doctors. And there are hundreds of thousands of women, because I'm on social media, that are doing this to change their care. And so from a physical therapy standpoint, I think the same thing is going where you could have chronic back pain. And how many times you're like, oh, my back hurts. Well, you go to someone, they refer you to a specialist, and then you're doing the runaround and like, oh, we could give you injections. Oh, here's all these pills. And at the end of the day, you're paying for things and the root of the problem's not being fixed, compared to someone that sits you down and is like, here's a root problem. You're not sleeping. You have a terrible nutrition. You're not even basically moving. You're sitting behind a desk for 10 hours a day. And so if I'm a physical therapist and I'm learning about this MAHA model itself, I'm like, how do we propose some kind of functional movement coaching thing where there's a lot of people already intuitively meeting together, but it's all cash based. And a lot of people don't know about it unless they're on social media. But your general, 50-year-old lady with back pain that's now, always getting injections and is only like, she doesn't know about what's out there on social media.
That's right. Yeah. Okay. So a couple really good points, right? Like social media those who are posting on social media, they have a different incentive structure built into what they're doing. I think about everything in terms of why you're doing it. Is there's an incentive, all of our behavior, there's an incentive for why we do everything. So if I'm posting on social media about like how to manage PCOS, for example, I could be anybody, right? I could be anybody. I don't even have to have credentials. But my incentive is to build my brand, and then, hopefully things come of that help earn me income down the line. Maybe I have a plan to sell a program, or maybe I have an affiliate strategy or whatever. I'm no social media expert by any means, but the incentive is my education, the time I take to share expertise, even if I don't have it. There's people doing it that are just like looking on the internet and sharing information. Hopefully we're not listening to those folks, but their incentive is there's going to be down the line, there's going to be benefits to me. It's not going to be the second, but I'm going to see something positive from it. Medicine, including therapy, anything that's billable, is purely transactional. We don't pay for something unless you're in an accountable care organization. We're not paying for some outcome that's going to come down the line. So in a roundabout way, right, social media posting about health and about health outcomes and about managing a condition or a disease or anything else is similar to what's done in accountable care. It's not similar to what's done in fee-for-service transactional medicine, where you're just doing, I'm going to use the term widget. I'm stealing this concept from, on my podcast, we just interviewed a physician who talks about how he's a physician specialist he's a surgeon. He just says it's just widgets. His surgeries are widgets. and the widgets are paid at X amount. And the more he does, the more widgets he does over the course of a day and a week and a year, the more money he makes, right? It's not that different for therapy or primary care. Our widgets are billable codes. They're time-based codes. The problem for us is there's only so many hours in a day, and that is going to immediately limit our reimbursement, and our reimbursement is not good. It's too low. So the math doesn't work, right? So you can imagine, like, I'd love to be, this is why PTs want to do things like cash-based practices, because they can, of the many reasons, I don't pretend to know what's in their head, but they know they can spend time, they can use their expertise, they can share that with people who they, are coming to them to pay to hear and care about that expertise, not because it's some secondary payer that's paying it. And they can devote what they know to be the highest value service, even if that's communication, right? And discussion and coaching. They have a reimbursement mechanism. It's called cash. But we don't have that in traditional medicine. Primary care docs who theoretically, with nurses in their practice and social workers and behavioral health, theoretically they, and I would argue with therapists in there too, should be providing this care to anybody. We don't do it because we don't have a billing mechanism. Cash-based practices give that. My issue, somehow we're going down the cash-based practice ave, but I think it's worth talking about to therapists. It's great. I get why you're doing it. The problem is it doesn't solve that access issue. We're not serving the population at large. We're solving for people who have money, right? And I totally understand that. Like, it is not, I'm not like sitting behind a wall going, oh, tisk, tisk, you shouldn't do that. Totally get why you're doing it. However, there are other solutions that if we could think about the way we think about social media and how we intend to earn down the line, if we can think about the investing in learning about how accountable care works and in how partnerships will pay off when you think about them in a different way, and you think about what if I can show that my service yields a high ROI for anyone in these programs, I can then, once I show that, earn some of the savings back myself. If we can get therapists thinking and excited about that the way they are about cash-based practices, which are really not that different, we can be part of the conversation and move the profession forward as a whole. These are pockets. They're similar ideas. But do we care as a profession about being part of mainstream medicine, even when it hasn't been kind to us when it comes to how we're reimbursed? Keeping in mind that this is because of everything trickles down from CMS. CMS has been influenced by the American Medical Association, who creates the codes and weights the codes and has created and weighted them for specialists. Primarily, right? They're the ones that have benefited from it. No one's going to argue with that. Remember, this administration, through this CMS, took big steps in this physician fee schedule to say, these non-time-based providers, we're paying them too much because they're more efficient than they're letting on. They've become more efficient in what they do. We don't have to pay them so much because they can do more now. We're going to take some of that money and we're going to give it to primary care. So back to my question I posed at you originally, what I would say to CMS is, if I was a therapy group, right, or I'm the APTA or I'm any therapy organization, I would say to CMS, we are part of primary care. We are mainstream evidence-based medicine. We provide evidence-based care that's low cost and high value, and we are going to become extinct and unavailable when we should be ramping up to provide care to probably 10 times the number of patients we are, seeing them much earlier, and for less intervention. We are getting patients too late because the system has never been structured to get us in front of patients when they need us, which is, I have low back pain. It's going to take 3 weeks to get into my primary care. It has now either worsened or I have gone to a specialist in the meantime or whatever it is, instead of us being in that primary care, right? And being paid, if we're on the outside and not part of primary care, for all of us, having reimbursement mechanisms that allow us to open access, to have more therapists available, better hours. So you have a patient with back pain, we can see them the same day, right? We provide urgent and primary musculoskeletal care. We can't do it the way we're paid right now. It's not enough. We need to be elevated, viewed as primary care. We need to make that argument to CMS. They're not going to figure it out themselves. This isn't how it works. We can't just complain about it and say, why aren't we paid more? We have to show we have ears that are willing to find solutions, ears willing to listen, to find solutions so that providers besides physicians can offer access, evidence-based care, efficient care, and avoid the high-cost care. Why aren't we doing it? Like, I feel like this should be our number one goal while we have these folks in place that have this mission. They keep telling us over and over again in everything they put out, here's what we're trying to do. Well, you just have to decide we're going to take it seriously and come up with the right solutions. Now, I'm going to pause for a second.
Thanks for listening to another episode of Strata Stories. Strata PT combines your EMR and billing into one automated system to increase revenue and achieve a 99.99% reimbursement rate for physical, occupational, and speech therapy clinics. If you'd like to learn more about Strata PT and see how our EMR and billing services work, head over to stratapt.com to book a demo.